these new immunotherapies and how we are going to adapt our practices and do the best we can to help patients. I would just ask if my screen is shared and available. Dr. Roa, can you confirm?
Yes.
Okay. All right. So these are my disclosures. I'm going to talk about these medicines, and I serve as a consultant for the companies that made these molecules, and I'm the president of the society that benefits from collaboration with these companies. So take this in consideration as you hear me speak. What we're going to do today is review the basic tenets, first of all, just to set the stage of how we're going to discuss cases related to Alzheimer immunotherapy case selection. And there's going to be basic rules of thumbs that we're going to go over. And then we're going to delve right into cases, discuss how to reason through these cases and how to counsel patients in regards to these medications. It would be fantastic if we are able to engage in a discussion. I know Dr. Roa and some of my other esteemed colleagues are in the panel. So it would be great if we can turn this into a discussion to teach each other, because I really don't know um, that anybody knows the exact correct answers to some of the questions that we're going to pose today. So a good spot to start would probably be this slide, which specifies how we now think of Alzheimer's disease in a biomarker-dependent way. We no longer think of it simply as a clinical syndrome, and we define it and link it to the presence of biomarkers. Which biomarkers? Well, those for amyloid, tau, and those denoting neurodegeneration. This is how Alois Alzheimer defined the disease more than a century ago. And today we're upholding the pathological definition of Alzheimer's disease. How do we demonstrate these biomarkers? Well, we have imaging biomarkers, including amyloid PET, tau PET, and for neurodegeneration, you have FDG PET and atrophy detected on the MRI. And you have fluid biomarkers. By fluid, I mean mostly CSF, which we're used to using, we've been using for a little while, including A beta 42 in the ratio to A beta 40, and then phospho-tau related indices, and there's neurofilament light chain for neurodegeneration. We used to use CSF biomarkers to define Alzheimer's disease's presence. And now we've recently been using, and you'll hear me talking about plasma phospho-tau 217 levels to indicate the presence of amyloid pathology. And even though it's a tau biomarker, it's a tau test. It's a biomarker for both amyloid and tau pathology. And along this spectrum, we define whether somebody has a positivity or negativity along the three axes of this staging scheme. And basically, if you don't have amyloid, we are going to say that you don't have Alzheimer's disease. And this was basically summarized in the suggested diagnostic criteria paper that was recently published, which shows and emphasizes that biomarkers is the way to go, almost saying that it's regardless of the presence of clinical symptomatology, although this remains mostly in the research realm and is controversial. But there's statements in this paper that say that basically, if you have Alzheimer's disease, if you have amyloid, you have Alzheimer's disease, or you will develop Alzheimer's disease at some point in your life if you live long enough. And it's important to also highlight the point that we now um, think or recognize clearly that amyloid pathology starts to develop in the brain decades before the onset of clinical symptoms. There's a window of opportunity of a couple of decades to intervene and hopefully interrupt the amyloid cascade hypothesis, which is the hypothesis guiding us through our disease case definition and guiding how we approach treatment. And this holds regardless of whether you have mixed coexisting pathologies or regardless of your cognitive reserve. If you have amyloid and you have mixed pathologies, you may be symptomatic earlier than if you didn't. And if you have cognitive reserve, if you're highly educated, or if you have certain genetic factors, you will be symptomatic later or never. All right, and so this is p-tau 217, which I mentioned. It's a blood test that we are able to order in certain centers, and it tells you whether you have amyloid and or tau, and it gives you a 3-level um, reading, meaning if you're above a certain level, you're highly likely to have Alzheimer's disease neuropathologic changes. If you're below a certain level, you are highly unlikely to have Alzheimer's disease neuropathologic changes. And if you're in between, you are indeed requiring further testing to answer that question, either with CSF or amyloid PET. It was shown that at these levels, the p-tau, plasma p-tau 217 is both sensitive and specific, more sensitive than specific, but both highly sensitive and specific for the presence of Alzheimer's disease neuropathologic changes. And it has really revolutionized our practice in clinic, as we may see. And who are the patients in whom you may consider amyloid immunotherapy? Uh, these are this is the gist of the clinical criteria that was used in the phase 3 clinical trials of the lecanemab and donanemab. These are mild AD or mild cognitive impairment patients. They are not moderate, not severe stage Alzheimer, so those would be excluded. Your clinical dementia rating stage is less than or is 1 or 0.5. We do not give to asymptomatic individuals, and we don't give to people with a clinical dementia rating of 2 or 3. The typical mini mental status examination is 20 or 22, and it can be more than that. It can be 20 to 30. In the lecanemab trial, it was 22 as a cutoff, and in the donanemab trial, it was 20. And perhaps the MMSE is the one that's most frequently used. So just to give you an idea of what your patient's performance in clinic might look like. And there's an asterisk here. We say clinically compatible with AD, not clinically typical of AD, loosening the boundary there on what AD might look like. And then you have to have biomarker evidence of the presence of amyloid. You have to obviously rule out certain masqueraders that may look like Alzheimer dementia, but they're not. There's a list there, and the American Academy of Neurology has a rule out test list that you can resort to. And then there are no contraindications, no debilitating illness, no microangiopathy or macroangiopathy in the brain, no major bleeding tendency. And you want to also look at your ApoE status, because if your patient is ApoE epsilon 4 homozygous, the risk of having complications related to the immunotherapies, namely ARIA, is significantly increased. Heterozygous is increased a little bit, and if you know that that's the genotype of your patient, you want to counsel your patients in that spirit. And the message is that we have to stick to the clinical trial inclusion criteria and try to not deviate from it as much as we can, especially in the early stages of applying or using these medications. And so just without further ado, that's basically what I said. You also have to be within the age range. You have to not be immunosuppressed, since these are immunotherapies. Um, and when do you pause? You pause when patients and families are hesitating. This is not the kind of medication where you want to push onto your patients. This has got to be a joint decision because of many factors, most importantly of which is that these medications slow down disease progression, but they do not lead to stability or improvement, certainly not improvement in cognition. And therefore, patients will see their loved ones deteriorate on the medication, even though they're regular with their infusions. You have to be careful when expectations are unrealistic on where you're or when you're deviating from clinical trials. Some of our uh, patients' ethnicities were not represented in trials, so the trials were done mostly in the West, and the most represented population was the white Caucasian population. So you want to consider if your patient fits that background or not. And whenever there's a source of a conflict of interest, for example, when patients are paying out of pocket or you're in a position to directly benefit, you want to make sure you are balanced in how you present the treatment to your patients, and you want to take your time and not rush into it. All right, so on with the cases. I would say, Dr. Rora, is there anything you wanted to add? Or, oh, I see Dr. Walid here. Are there any additional points you want to mention about how to generally approach presenting these meds to people? Feel free to jump in now and at any time, please.
Sure. No, nothing to
Uh,
add so far.
all right, cool. So let's do some cases. So this is a 65-year-old man who presented to me with progressive memory decline for 4 years, was with his family. The wife was tearful. It was a typical presentation. Patient was repeating questions and misplacing things and forgetting names of familiar people, and something that denotes episodic memory deficit. He was also irritable and potentially paranoid. Was a problem at their home that he was blaming his son for. He was talking for most of the visit about how his son was trying to take over his house um, and portray him as demented. He had no other cognitive problems to speak of and no other neurological symptoms, and he was really functional, mostly in his daily living activities and instrumental daily living activities. This is his past medical history. Not much to report, um, and he has family history of dementia, a strong family history of dementia, and he was still functional. He worked as an electrician and had a concerned family. This was his exam. His BP was all right, which again, the blood pressure is one of the things you pay attention to when you're thinking about immunotherapies, because a high mean arterial pressure increases your risk of ARIA. His digit span showed intact attention. He was attentive throughout the interview. He had some trouble recalling details of current events, and this is his minimal status examination. He lost a few points that he would think he wouldn't miss sitting across from him, related to orientation and where we are, and related to, obviously, he lost all of the recall words, and he ended up getting 23. Um, I use the functional activities questionnaire to gauge daily living activities. The higher the score, the less likely you are to be independent in your daily living activities. And you can see him having some difficulty there in some of the complex tasks related to finances and independent shopping and some of his appointments and so on and so forth. certainly in the mild range. This is his workup. The most notably, his MRI was basically normal, and his tau 217 was quite elevated at 1.4. And here, this is what I was talking about, the three levels you get. And, if you folks agree, this seems like the situation, typical situation where you would want to offer folks the amyloid agents, and I did. And I sent them to the amyloid PET, and this is the amyloid PET showing lack of. They all look the same. You don't see gray-white differentiation, and this means you have amyloid and R nuclear medicine folks use a grading system. So they call this a beta amyloid plaque level 3, denoting a high load of beta amyloid, and you see it in the lower cuts and the higher cuts as well. This whiteness where you no longer see that perturbs your view of the gray white. So I talked to them about it. Unfortunately, I could not convince them, even though this was probably one of the ones I felt most comfortable offering them the treatment. They would refuse, potentially because of the paranoia related to and the denial of the treatment. And that's not the only case where I failed. There's quite a few that I've failed. This is another one, a 68-year-old, and you can see presents with a typical story, again with a family history. And this was even higher functioning and milder than the previously mentioned patient. And the MoCA score was 26. The tau 217 was 0.4, and the amyloid PET was positive. There was a little bit of mesial temporal atrophy. Um, and again, the patient and the husband were reluctant. She was fully functional, and they were like, "Well, we're okay, and since we're still barely symptomatic, we can wait a little bit until we're more symptomatic." And I think it all comes down to how you present the treatments. And again, my approach is not to force these treatments on anybody, and to just present the data as much as the patients can take it and as much as possible. Um, this is what I would typically say. I would say you're coming today with memory symptoms that show the parts of your brain are not quite working. And the tests that we did show that certain proteins, namely amyloid, is deposited in your brain, and potentially another protein called tau, and that you're in the early stage. And if appropriate, you name the stage, or there's MCI or early Alzheimer. And I emphasize that this is a progressive, slowly progressive disease. And there are medications that we're going to prescribe that alleviate symptoms but don't slow down the disease. But there are now approved medications that remove that protein from the brain. And then I talk about the extent of the benefit. I make sure I tell everybody that it does not stop the progression, it does not make things better. And I also tell them that the improvement, you will read that the improvement is 20% or 30% or a delay of 6 months, but I also tell them that they will see the patients dwindle in front of their eyes as they're doing the infusions. I think this is important because it sets expectations appropriately. And then I talk about the infusions, whether they're the monthly or the biweekly, and then we talk about the risk of side effects, and I emphasize the eye part of ARIA, that they're imaging abnormalities mostly, and that the vast majority, almost the entirety of the cohort that develop ARIA are asymptomatic. I tell them how likely ARIA is likely to develop. And then I talk about the importance of doing ApoE. And then I talk about the need for frequent MRIs. And, not surprisingly, a lot of people, it's not just my um, charming way of presenting things, but there are reasons why people decline. Neuropsychiatric symptoms is one of them. Thinking it's too early is another one, even though there's data now that I'm starting to propose that, the earlier you intervene, the better. Some people don't even want the label, and some people just don't think it's worth it. Some people don't want to get the MRIs. I've had patients who decline simply because they have to do these MRIs every now and then. And then the complications is the last one. So the conversation I think is important, and we need not go overboard as we're presenting these medications. Um, any comments about what to tell people in the clinic? Dr. Najib is in there. He should be the best person to tell us what to tell patients in the clinic.
Thank you very much.
No
No,
comment.
I'm not the best person to tell, but it's really quite intriguing, and it is difficult to convince patients. First, you have to be sure that as you mentioned, that there are significant side effects. There is a benefit, but it's not really going to cure them. Unfortunately, the news, what they hear, is very different from when they come to the clinic, and that's what makes them like uh, a bit disappointed, because they hear a lot in the media that like it's going to cure all your problems.
Yeah,
So I'm really facing the similar problems. It's not easy.
yeah, it's not. And there are people that come in the door saying, "Hey, doc, I want to get that PET scan. I want to get that CSF. I want to get that medication." And these are exactly the people that might be disappointed. And it's interesting that the amount of time we spend doing the cognitive exam in clinic it's been reduced, and the conversation has become lengthier. So I concur with you, Dr. Najib. Any other comments or thoughts? I'd really like this to be it would be great if this isn't as interactive as possible. Please feel free to unmute and stop me, dear panelists. But the next thing I think is important to do is staging. And I find myself in the clinic asking, this patient seems to be presenting early, but are they really early? And then vice versa, this patient seems to be presenting late. Are they really late? And I'll present a couple of cases that demonstrates that. So this person is 74-year-old right-handed man who I saw with his son and wife. And again, they came in saying, we want a new treatment. And the patient's been declining. And again, typical history. Um, he has a history of remote alcohol use, not recently. So alcohol-related cognitive impairment dementia is in the back there as mixed pathology potentially. And without really complicating things too much, this is his mini mental status examination right at the border at 22, with again a few points missed here and a few, all of the memory points lost as well. And I'd be interested to hear what people's approach is. I typically, if people start to have difficulty with the orientation questions, I just carry on with a mini mental status examination because the MOCA would probably be too difficult for them. And I have access to a neuropsychologist, so I end up sending people to neuropsychology all the time. So again, the typical behavior neurologist that sits there and you know takes out coins and looks for barognosis is going to be limited in terms of these Alzheimer clinics, at least. This is the FAQ. So the cognition was borderline moderate. The FAQ was also borderline. 20 is my cutoff of really saying that you're too impaired. And on the fast, if you're putting on your clothes by yourself, you're considered sort of closer to potentially early. But you see how there's subjectivity there, and that's where some of my difficulties arise. So the MMSE here is within the inclusion range. This is sort of borderline, neuropsychology was sort of the same. They were like, this is mild dementia, but borderline moderate dementia. And these are the test results of tau 217 of 0.89. So definitely indicating ADNPC, and amyloid PET was BAPL3. And when he came in, he already came to me with FDG PET showing neurodegeneration. And this is brain MRI. So it was a cavernoma. So tell me that you're brave enough to offer him the immunotherapy. Um, Najib is very brave. Walid is also brave. Roa is as brave as I am. Would any of you offer this patient in this context to be on lecanemab or donanemab? In summary, a patient on the borderline between
Yeah.
early and moderate. But if you strictly speak, if you strictly speaking, you can think that they're early. And then with the brain MRI that shows a cavernoma.
Well, it might not an absolute contraindication, but given that he's already borderline, I might rethink that.
Yeah. I think
I
I
honestly
was
would not. I'm
you would know.
maybe with age you get a bit, like less. I'm not that confident that I'll give this patient this medication. I would refrain from giving.
Yep. Thank you. That's exactly what I did. I counseled them extensively that it's a risky intervention of which benefits, in my opinion, outweighed costs. And I'm not sure, this is not evidence based, but when you see neurodegeneration, you're already wondering how much you're saving. Especially that, I've seen tau 217 levels a lot higher than this with no evidence of neurodegeneration. So that, along with the cognitive exam and neuropsych, are making me think that we're already beyond the early stage. And then the risk was amplified by I think was amplified. We talk about micro and macro angiopathies, but I think a cavernoma is probably something like that, even though, you know, do cavernoma vessel walls, if those exist, have amyloid in them? I think that's an interesting question, because that's why people have increased ARIA risk because of amyloid angiopathy. Does a cavernoma have amyloid angiopathy? I don't know, but a cavernoma can bleed, and it wouldn't be my desired outcome. So I think this case demonstrates that it's not really just a box ticking exercise. It is really the judgment is very much still in play. This is another person, 89, so at the borderline of the point where you would say they're too old. A highly educated person, a professor of electronics and electric engineering, who had been practicing until a little bit before he came to see me. He had 3 years of memory decline, was still fairly functional, but started to drop some of his IADLs. He has significant vascular disease in the past. He has family history of dementia. This is his MoCA, lost all of his memory points. This is FAQ. This is his tau 217.96, positive AMI-PET, amyloid, APOE34, and the MRI shows white matter disease and mesial temporal atrophy, but no evidence of microbleeds. And neuropsych confirms profile typical for Alzheimer disease. So my question is, well, at least what I was wondering at the time, this person is by strict criteria mild, but how would you, he has high cognitive reserve. So the question is, did he accumulate enough amyloid in there to make him pathologically beyond the early stage? That was my question. And I know I'll confess that this person is on treatment at the moment and is doing really well. No ARIA through a few months already of lecanemab. Would you disagree with my decision to offer treatment?
Uh, can I argue that?
Absolutely.
Okay,
Please.
thank you so much.
I
So,
love arguing.
so basically, the way I would approach it actually is the time to benefit. So in geriatrics, we'd like to think about it from that perspective. What are the competing risks that he has? Is he otherwise like frail or non-frail? Um, and honestly, how much his amyloid pathology is contributing to his functional decline compared to basically other like other co-pathologies, like even neuropathological changes. So and I would add in like other factors also into the mix, addressing like cost, distance to treatment, frequency, and so on. And then I would make honestly my decision. If they definitely value the marginal benefit and the value of living around like extra 6 months or 8 months within the MCI, or like in the mild cognitive dementia over all the other aspects, I would continue with the treatment. If they value like basically all the other like social determinants of health, or all the other variables like that can like affects their quality of life, I will have that kind of frank discussion. And to be honest, a lot of people would definitely value that extra 6 months of like
Yeah.
waiting to attend their grandchildren kind of graduation party or things like that. So you cannot make that judgment, but you have to engage them, and it's kind of a multi disciplinary and shared decision making. It becomes way difficult. Like honestly, the same thing applies. Like, okay, would you give anti-resorptive medication for like osteoporosis medication for people in long-term care? Like, what's the value? What's the time to benefit? And we have that argument all the time with frail people, especially when they cross the boundary of like 85, and whether they will also well represented in the studies as well to make that judgment. But again, I think I'm sure you made the right decision after having a shared decision making with the family.
Yeah,
I,
I agree with you. I'm not 100% sure we made the right decision, but we discussed those very factors. And this is a professor who was fully functional, who was beat vascular. His cabbage was a couple of decades before that, and vibrant with life. And he was, he's the center of attention in clinic when he was there. And the prospect is that he would live to 100 and beyond, and so on and so forth. And that's the context in which the decision was made. But I thank you for expressing those things so eloquently, Dr. Walid. Dr. Roa,
I,
Dr.
I,
Najib.
I just have a question for you. How, because I know this is at the border. Like if we are going with Gregorian, this is 89, but I'm sure they don't take Hijri, so he's 92. He's beyond the from 50 to 90 years. So I'm impressed, really. I agree with you that you're looking at how he's full of life. How did the patient do? I mean, has he taken several? Have you just started him on this, or has he taken, like for the last few months, he has been on this medication?
Yeah. Right. So he's taken, I think, 10 infusions or so until at the moment. He's doing really well. No ARIA. He's doing, I mean, he's doing okay. I mean, there's no major, there's nothing to report, obviously not better, but family seems to be saying that he's the same. So I think
Was
that's
he
the
declining? I mean, him being the
the-
same might
hi-
be that he's
his
plateauing.
scores
No,
are
I
the
mean,
same.
okay, Okay, this is impressive. I mean, kudos to you, really, to push an 89-year-old professor to give. So it shows the value of life. Like he's full of life. You're looking into all these things. This is impressive. This is really at the border. Thank you. Thank you for sharing this case with us.
Yeah, no, he pushed me actually. You know, then that's how I like it. It's like I try to dissuade them from it, and you know, talk about it more objectively. And again, I think this discussion is what I really wanted to come out for all of those uh, 500 plus participants that we have here. It's really it's complex decision making and clinical reasoning, and there's really I mean I will admit that I am not 100% sure of the decisions, and it's really almost entirely dorsolateral prefrontal, and in trying to stay away from pattern recognition and reflexive thinking. And I think we need to stay at that stage for the next bit of time until we're all comfortable and we know exactly what these meds do and how they're affecting our patients and families. So thank you both for saying what you said. Dr. You're unmuted. You want to say something?
Um, yeah, I had two thoughts. First, I would not put a lot of weight on his high tau given his age. So the first thing I was thinking was how bad was his white matter changes on MRI? And were you able to follow him for a good amount of time to see him declining on like objectively on testing?
Not before. So I saw him and we decided to go on treatment on the first visit, actually. So I have not really seen him decline. And to me, just the subjective impression is that he's basically the same as when I saw him um, a few months ago, you know,
Yeah.
uh,
Okay.
6 months ago. So. But you know, he's amyloid PET's positive, so he's got amyloid in there
Uh,
with high density.
there are a couple of hands are raised. Are you gonna look for their questions or allow them to also intervene?
Oh,
Yeah,
you
I'm
guys
following
are.
up in the chats for any questions. Um,
Yeah.
there was
And
actually
you go ahead.
yes. Hmm.
No, go
There
ahead.
was actually one question. Someone was asking, amyloid can be positive in so many cases. How do you know it's Alzheimer's?
Oh, isn't that the $1 million question? I think
Yeah.
the short answer to that is if well the you know the easy point to make is that it's an operational definition, right? So if you have dementia and you don't have amyloid, you have the kind of dementia we're not talking about here. It could be vascular, it could be Lewy body, it could be frontotemporal dementia. So you don't have the kind of pathology and potentially not even the kind of clinical presentation that we would call Alzheimer. So the difficult part is that a lot of people with amyloid, or at least a proportion of people with amyloid, don't end up developing Alzheimer disease. And there's still some missing data on this. And I think the gist of it is that if you live long enough with amyloid, it means that that amyloid cascade hypothesis leading to neuronal injury is going to eventually lead to clinical symptomatology. Um, so the impactful question here, if somebody has amyloid and they don't have clinical symptoms, would you treat amyloid? And the answer is no at the moment. There's trials ongoing to look at pre-symptomatic individuals who have amyloid and see what their long outcomes are. But at the moment, we're saying if you have amyloid and you have some cognitive syndrome, then you are, and you're early, then you have all, we think we label you as having Alzheimer disease, and we think that removing amyloid is appropriate. Um, So I can't answer how to determine whether people with amyloid in their heads and no clinical symptoms are going to end up developing clinical symptoms or not. There's certain factors that you can use, but if you have amyloid and you're in your early late age, so past your 60s, and you're projected to live for a couple of decades, and you can be followed, and your clinical performances indices can be followed, and then we can determine whether or not you have Alzheimer disease or not. That would be my answer to this difficult question. What would your answers be, professors? I'm distributing the burden.
Well, I think you nicely explained it. So, the presence of amyloid per se just means that you have amyloid in your brain. Unless this builds up to tau accumulation, and as you can see here, some specific phosphorylated tau like 217181, it does not mean
Yeah.
a lot. And then if that does not translate clinically into um, clinical symptoms, again, presence of amyloid per se. Now, again, I was just saying that nowadays you can easily prove the presence of amyloid. Now the question is it causing anything or not? And that's now what we need to do in the clinic to see, is this amyloid over there causing anything or causing the clinical picture or not? And that's where our role comes. Otherwise, proving that
Yeah.
amyloid is there is very easy nowadays.
Yeah, and there's a couple of cases that I'll actually present later on that highlight this very difficulty.
Okay.
Great, awesome stuff. So then this is another case, a 71-year-old with slowly progressive forgetfulness. And this is FAQ, sort of borderline. He had significant depression, and rheumatoid arthritis and lots of pain from degenerative disc disease, and was started on analgesics and sedatives, as you can see, clonazepam and oxy, and was also on Seroquel. And he was quite depressed when I saw her. Did terribly on her cognitive examination. I thought this was potentially moderate dementia, and potentially some encephalopathy related to meds, and untreated depression. So we treat the depression. We start donepezil. We get her off of the high doses of clonazepam and oxy. She's still on a little bit of oxy, but she got off most of the She got off the clonazepam completely. Her depression significantly improved, and lo and behold, her cognition also improved and her functioning improved. And now she looks like she's a mild dementia. And here's your tau 217, and your amyloid PET was positive, and her ApoE4 status is homozygous, and that's her MRI brain is clean as a whistle for her age. So what would you do? Would you treat or would you not treat? She's on methotrexate, which is not really a biologic. But I'll leave it to you. Would you offer this person treatment? And she sustained this improvement. This cognition was sustained. So she remained at her, and I'm not sure I show her neuropsych. I don't show her neuropsych, but her neuropsych also significantly improved after I got her off the clonazepam and the oxy. But she still had memory issues subsequently. So what would you do?
What was
She's
her
ApoE
age?
homozygous. She is 71.
Okay.
She's a dog.
Well,
She's independent. She has help that comes at home. She lives alone, but family lives downstairs.
Well,
What would you
given
do?
her EPO-E4 status, I would be hesitant, but I would counsel her. I would give her the option.
Yeah. Yeah, that's exactly what I did. And if they ended up declining, when we found out that she's ApoE homozygous, ApoE epsilon 4 homozygous, she ended up declining. They said they would think about it. So not complete. It's not an absolute contraindication, I
Mm,
suppose. Um, but I framed it so that in these early days we'd minimize complications, and it was sort of easy because she was on the upswing after coming off of her um medicines. And I think this is another case where she seemed late, but then when you look at different causes, Alzheimer is not the only thing that impacts cognition.
mm.
uh the behavior neurologist is still important. So it's still not just tests that you do and needles that you put in and infusions that go through. I thought this was a very instructive case. Comments, or you move on to the
No,
next one?
yeah. The
We've
fact
kind
that
of, yeah.
I would I would
Mhm.
I would be very cautious in general with whatever we call absolute or not absolute contraindication, because we're still learning about these
Yeah,
medications. And
absolutely.
you see the new recommendations, like not like to it's not, again, it's not yet an absolute contraindication, but there is a lot of caution around EPOE homozygous patients.
Yeah.
So anytime I feel hesitant, I think I will transfer my hesitancy to the patient, so we can have this shared uh, insights. But yeah, the fact that it's not an absolute contraindication does not mean that it's not risky.
Yes, I agree. Obviously, some people will say, well, it's those people that are at higher risk of potentially the ones that need the medication the most. And I think we still, I agree with you. We still need to understand exactly what the long-term outcomes are going to look like for ApoE epsilon. So unless somebody really pushes me for to go with treatments, I would not necessarily agree. I would definitely do, and I think I successfully dissuaded them here. All right, so we can still do a few more. Let's see. Um, so diagnostic questions. Are things what they seem? So so the title of this case is White is the Matter with Her. 75-year-old female, um, forgetful for 1 year. I was not really impressed by her forgetfulness. It sounded more like the conversational inattention, difficulties retrieving things. Um, she had a lot of anxiety about world events and wars and so on, to the extent that she wouldn't sleep at night. But her husband was with her, and they're both highly educated, and they were concerned about potential true decline. She used to be a school teacher, and her son, who's a physician, noted that she was just always on the ball, and she no longer was. Um, this is from her neuropsych, which called it multi-domain um, MCI with mixed potential pathologies. So Alzheimer was in there, but vascular depression. So you getting the frontal subcortical flavor here. Um, and we talked about anxiety and sleep potentially being the main culprits here. And then this is her brain MRI. This person does not have vascular history, so no hypertension, not diabetic. But white is the matter with her. So she has this obviously florid bilateral white matter disease. You wonder whether it's actually vascular. And I wondered whether it's metabolic or whether it's a form first of a leukodystrophy. Particularly given her background. I also wonder, you think of Cadisil, given the presence of anterior temporal abnormalities here. She didn't really have um, the headaches and no significant family history. And so you think about these things, and you say, well, this it confirms this being a subcortical process. And what I did was I ordered this stuff. So her vessels were clean. There were no microbleeds in there. There was nothing to indicate significant vasculitis. This is her tau 217, and this is her amyloid PET. So what would you do? Who would you treat? Positive amyloid with some memory decline.
I would not
And
treat with
I will
this.
tell you that she and her family want the treatment.
Well, with this amount of white matter changes, I would not.
Okay. Waleed, Dr. Najib, what do you think?
The white matter lesions are really significant. Now, the issue is,
Yeah.
when do we consider this like, what is an indication, a clear indication? I doubt if there is any clear indication. When do we consider that the white matter load, is it heavy or not? But I agree with Dr. Roa. I would refrain from giving it. I would like to know more about ApoE. I didn't see the ApoE part. That will make
Oh,
me.
yeah, she's 3-4.
Okay,
I should
she's
add
three.
that in there. She's three
Okay.
four.
Yeah, I honestly would refrain from giving it the medication. I would be very cautious. I would
Yeah.
not give the medication.
Dr. Haitham, do we have a tau PET on her?
We do not have a tau PET on her.
Actually, it would be
I
kind of
don't have
helpful.
access to a tau PET. So
Okay, but
what were you thinking?
so it would be really helpful to have. It can add some insights. If she's like in the highest tertile of the tau PET, kind of the burnt out phase, she might not benefit from the treatment. So it can help us tease out that piece. If she's kind of in the middle low tau, it can be a little bit helpful. So it might be helpful actually to guide how significant that amyloid pathology is contributing to her symptoms, beside the significant vascular co-pathology. But I would say like it's obvious that the vascular co-pathology here is predominating, and it would be it's a tough call, honestly, but I would like to see her tau PET before making a final decision.
Okay, that's all really great. So we had a similar discussion at our rounds, and she's receiving her. She's in the early stages she's on lecanemab. So she received, I think this would be her third or fourth infusion. With the radiologists thought that this was not really typical white matter disease. Her BPs were consistently low, and it looked like this was present for a long time. The radiologists thought it was a tough discussion in the clinic too. And long and short of it, despite my you know hemming and hawing, the decision was finally made to go on treatment. So this is one of my 8 patients who are on treatment uh, early on, and I'm nervous. I agree with everything you guys said, and it's very carefully documented. We don't have bleeds in there. We don't have macroangiopathic changes. They're of the ethnic background where these white matter changes may be prevalent as form firsts of leukodystrophies. I tried to search hard whether there is somebody in the family who developed leukodystrophies, but we couldn't. We sent for a panel that came back not showing anything specific, a leukodystrophy panel. So I'll let you know if this ends up being. I actually have no ARIA cases yet. And you know, if one was to develop, I wouldn't be surprised if it's this one. So I I was reluctant, but it was the decision, shared decision, just like you said, Waleed, and we'll see. I mean, I think people who are, especially those with high education, who are worried about um, long prospects of their cognition and functioning, and who have the means, wouldn't necessarily object to having the and actually we delayed the decision for a few months and just to make sure that they're firm with their wishes. So again, tough decision, and we made sure to discuss it at our rounds, and this is no longer even my decision, and that's how it's documented in the records. So we'll see. I'll let you know next time. Next case? Maybe next case. So this is, who is this? This is a 65-year-old high-level, oh yeah, I know this one. So high-level executive who had a aortic valve replacement, has hypertension, and 6 months after that procedure, the surgery, he had an episode of loss of consciousness. It was not really clear whether it was a seizure. It was not really clear what happened. He was sent home. And then when he came to me, he was brought in with family with progressive changes in behavior. He was somewhat forgetful, but not really the kind of forgetfulness where you misplace things and so on and so forth. And it was changes in personality, and he was no longer himself. He was the back of the room despite being at the center stage. He had apathy, abulia, low motivation, and then that would alternate with the opposite: risky decisions, losing a lot of money in stocks and business endeavors that were not really well thought through. He was actually diagnosed with bipolar disorder, started on these meds that you see, and really no other neurologic findings. He snores, no obstructive sleep apnea. This is how his exam looks like. And again, the family came to me asking for potentially going on treatment. And I put this case up here because of the word masqueraders I referred to earlier, and because of the alleged push to dissociate clinical from biomarkers. So this progressive behavioral change and memory change was associated with these strokes, which seem to have happened somewhat after at some point after his surgery. And this is probably this lesion and a little bit those lesions, and that lesion is probably why we're getting the abulia being in the dorsomedial prefrontal cortex, and potentially this big dorsolateral stroke that is interrupting the unseen fasciculus, most likely dissociating the ventromedial prefrontal cortex from mood, so dissociating decision making from the impact of mood on your decision making. is why he's been risky and why he looks like he's bipolar. And so I think there are plenty of masqueraders that we need to consider: stroke, GBM, um, uh, uh, autoimmune encephalopathies. We're learning more and more about chronic autoimmune conditions that do not necessarily present acutely. Um, Vitamin deficiencies, thiamine, malnutrition, low-grade tumors, you name it. And I think one of the most important lessons is to be humble and this was an obvious case that popped up in the imaging, but one wants to look, hard for those masqueraders. Panel, are there any other masqueraders that we need to be aware of or we want to highlight for our audience? Dr. Najib, Dr. Walid. What potential masqueraders should we also highlight? I mean, I typically order the thyroid and B12, and if I'm suspecting um, thiamine, I just give thiamine, and I might order thiamine level as well. Sleep, I order sleep all the time. That case highlights depression as a potential masquerader as well, and depression-related cognitive impairment.
Dr.
Any
Haytham,
other
if you think about it, you mentioned about a case which I usually see a lot, the patients who are on benzos, who are on other medications that cause significant cognitive impact. And amazingly, when you stop the medication, the patient really did get better. So, all these things we have to keep in mind. We usually forget these important aspects.
Absolutely. I agree.
And the sleep part, as
So
you just
again,
mentioned, the sleep, I cannot emphasize more because we don't think it's important. It's extremely important to look at how is the sleep pattern. The patient does not have an obstructive sleep apnea. There are nothing, there aren't other masqueraders which are really affecting these patients.
absolutely. Yes, 100%. So one of the main objectives I had in mind coming in is to highlight the complexities of these things. In different clinical practice contexts, one might find themselves um, without prior training, without appropriate resources, and with a patient population relying on them, and with information, not always from unbiased sources. And I think it's those exact situations where we need to be careful, where we need to be most careful, but we really need to be careful all the time, and we need to have these rounds and discussions all the time. And I think it's our responsibility towards our patients and their families. Dr. Walid, it'd be great if you could add a couple of points. Also, I see hands raised and questions in there. I'm not sure, Roa, if you want to address them now or later, just to change the pace. We have still a few more cases, but we don't have to go through all of them, obviously.
For the raised hands, I'm not sure because I talked to them privately asking if they have questions or if they would like to add anything, but I did not receive any response.
I'll leave that to you. I just want to make sure I'm not boring you. So we can move on to the next case. So this is a patient who some of you may have heard about this patient. So this is a 47-year-old who came in with her husband, quote unquote, forgetful, confused, not doing her house chores the way she used to. And she really sat there in the clinic, not talking much, and with a depressed affect. She was starting to make mistakes with her instrumental daily living activities, and she was treated with vortioxetine and bupropion for depression. She has obstructive sleep apnea. She does have family history of what was called Alzheimer disease in her mom, who was 70. This was her exam. She had significant word finding difficulty, lots of pauses. She had significant difficulties with repetition, lots of dysnomia. Her memory performance was okay. I mean, she recalled 4 out of 5. Significantly reduced category fluency, and these are her MMSE and MoCA scores over the course of a few visits. This is her her Luria. You can see a little bit of perseveration here. So you look at her and you get frontal flavor. This sounds and looks like a primary progressive aphasia of some kind, or you worry about this executive variance there as a differential diagnosis of AD. But you really think this is a PPA, at least that's how I thought. And she had, on her MRI, she had mild but global non-specific atrophy. And she was young, remind you, 47. So Center for Neuropsych confirms logopenic variant PPA as a profile. And for those of us who are not behavioral neurologists, logopenic variant PPA is the PPA that is typically associated with amyloid pathology, and it's an atypical presentation of Alzheimer disease. This was her PET scan, and you can see asymmetric hypometabolism. This is an FDG PET scan showing asymmetric hypometabolism in the dominant, more than the dominant hemisphere. The colors here, the higher the colors here, the more the hypometabolism, and as opposed to what you may be used to as being the colors lower, being more hypometabolic. And her CSF studies are amyloid AD neuropathologic changes consistent. So this is an atypical AD. The question is to the panel, given the fact that the new diagnostic criteria propose a reduced dependence on the clinical syndrome, would you offer the treatments to this patient? And I will tell you what happened just before to remove any. So I did not, but this was one of the patients who had access to. She was able to go to another place and get the infusions as an atypical, sort of an extrapolation from the clinical trials, which typically included patients with episodic memory deficits typical of Alzheimer disease. So would you at this point feel comfortable offering people with atypical presentations of Alzheimer disease, so logopenic variant PPA, or posterior cortical atrophy, or dysexecutive AD? Would you offer the treatments, or would you stick to the inclusion criteria in clinical trials?
I would stick to the inclusion criteria, at least in the beginning, before we have like real life evidence or a clinical trial including atypical cases. But if now I understand she's young and we have evidence, like we have a confirmation that this is a logopenic variant of AD, like PPA, which is an AD, and I understand that she's gonna progress, and I understand her decision. And but if it's up to me, I would not, at least in the beginning, until yani, we don't have yet experience with the typical ones to start with the atypical ones. So
That's very true. This is very true.
yeah, that's my
And
conservative
again,
approach, but I
I
don't
agree
blame
with
her.
you. I mean, no, I agree with you 100%. And that's how I had framed it to them. And when you get into the possibles. So the hypotheticals. Well, if removing amyloid works with memory presentations, why doesn't it work with language presentations? And I'm like, well, yeah, you are right, but we didn't demonstrate that in clinical trials yet. So she's received quite a few doses of I think she's actually on aducanumab. And I saw her decline over the course of my follow-up with her. Um, Dr. Najib, Dr. Walid, any additional
I
comments?
I would echo what Dr. Roa is saying.
Yeah.
I don't think it's a conservative way. It's the practical way. We have to gain
Yes.
experience. And you do understand once you go outside the clear indication, and if something negative happens to the patient, you're liable. I mean, like the
Absolutely.
enthusiasm the family has or the patient, it can turn against you once, like they say, well, okay, you really did not follow the guidelines. So at the moment, we don't have, like, I honestly speaking, I need to gain the experience to treat the typical patients. And once we have more trials, other things are coming, of course the other inclusions will occur with time. You were just talking about the new way. They want to consider everyone having just amyloid as Alzheimer's, even if they don't have any cognitive impairment. So, a lot of outliers are going to happen in this coming short time, and we'll see very strange things happening. However, I would
Yeah.
really stick to the criteria totally.
Awesome. Thank you for saying that. All right. So here's another one. Since we're having fun, we might as well have as much fun as we can. So 86-year-old with visual impairments, so she's legally blind. She is Charles Bonnet, or was told that she had Charles Bonnet quite a few years ago. She saw visual hallucinations of small things and squirrels running on the ground in the floor of her apartment. And she had come to me with these about a year ago with these very vivid hallucinatory experiences that her neighbors were having loud parties and that there were loud noises coming that she could hear the neighbor and her husband making loud sounds and interesting thing is that her neighbor is not married. She knew that her neighbor is not married, and it led to a whole social problem amongst the two families. And it was a delusion. In addition to the hallucinations, there was a delusion. And there was also some memory and attention issues. She would mix up Siri and Alexa. She also had some medical history, as you can see, recurrent UTIs. She had heart failure and she had exacerbations. I have no idea what happened there. She had exacerbations of her heart failure. Let me just bring you guys back up. Can you guys see it?
Um, okay,
Are you
now
back
we're
up?
safe. Yeah.
Okay, good. So, some medical history is what I was saying. Oh, and more medical history. As you can see, she's cardiac disease and she's AFib. And she's on these meds, including anticoagulation. And she was still functional. She lived alone with a helper. Her two sons live close by and come see her every day. She has past history of obstructive sleep apnea, and she talks during her sleep, but not all the time, but it happens. And she's anxious and irritable, especially in relation to those vivid psychotic experiences she had. This is her mini mental, 28/30. I mean, it's not a There's no need for suspense. So my leading differential diagnostic consideration was Lewy body dementia, given the vividness of her psychosis and the possible REM sleep behavior disorder. I thought there may be delirium, but she didn't really. She wasn't really. I think we need to take the main. Yeah. Okay. Good. So the other consideration is the presence of lingering delirium. But sitting across from me, she had a digit span that was reasonable. Let's see what it was if I had it up there. But I do say here that she had intact attention. Her attention is not impaired, which argues against delirium. Delirium does fluctuate though, so it's still in my differential. Seizures is the other thing. You can get occipital seizures that present with hallucinations, and if you're getting enough of them with sufficient spread, you can be periictally psychotic. So that's another differential, another masquerader to think of. An atypical AD is down on the list, and obviously mixed pathology is in there. So, having the luxury of having access to all these things, I ordered all of them. Isn't it easy and fantastic? So this is her previous stroke in the back here. It's close to the cortex, not terrible. There's a little bit of atrophy mesial temporally, right? Bilaterally. A little up here too. Fair amount of white matter disease. And then diffusion restricting the showering strokes, which made me a little anxious at the time. And we had her immediately see stroke after that and review her anticoagulations and so on, but there was nothing else to be done. I believe there was nothing else done. She had an echo and so on. So she was throwing emboli despite being on Xarelto. But anyways, that was stroke's problem. And then, she came back and she was still having those vivid experiences. And this is some of the workup that we did. So her tau 217 is positive yet again. I have a few negative tau 217s. It's not like all of them are positive, but the vast majority do end up coming back positive. Her DAT scan was negative. So Lewy body was sort of, I was hoping for that to be to confirm my initial suspicion. FDG PET showed no particular pattern. EEG, ambulatory EEG was normal. Her neuropsych was difficult because she had that visual impairment. And there was a little bit of visual memory that there were verbal memory that we're able to do, and there was difficulty with list learning, so denoting some episodic memory deficit, verbal learning memory deficit. And then she's 3-4 with her ApoE. So what would you do? So they want to go on treatment. Once again, this person is waiting for a decision. I can tell you what we discussed in rounds. We still thought that this was Lewy body dementia, despite the negative DAT scan, even though that has reasonable sensitivity, but the presentation was really typical. So would you? I think I actually have her amyloid PET. She is amyloid PET positive. So she would be BAPL2. She's moderate frequency of neuritic plaque deposition. So what would you do? Help. So summary 86 with psychosis, low-grade not really low-grade, vivid psychosis, medical problems, a active vascular situation, potential Lewy body dementia, but positive amyloid studies, what would you do?
Is she on anticoagulation?
She is. She's on Xarelto.
Okay. I wouldn't
And
put
I
a lot
think
of
the
weight
data
on.
show, at least for donanemab, that there's no direct interaction between being on anticoagulation and having ARIA E or H. There's no
Yeah.
increased risk of ARIA-H if you're on anticoagulation, according to the Trailblazer 3. But it's definitely a reason
Well,
for pause. And that
well,
was actually a
given
bulk of the discussion that we had in our rounds.
hmm. Well, given
To
her
give or
age,
not
she's 86. I wouldn't put
86.
I wouldn't put a lot of weight on her positive amyloid causing her symptoms. She has showering strokes. She has an occipital stroke. I would blame those vascular things for her symptoms, but
So
I would
let me
not say.
challenge. I want to challenge you. I agree with you, but I want to challenge you. Let me just see if she has family history. Unfortunately, I don't say that here, but that probably means that she doesn't have family history. But so she does have amyloid, and she's had it for a little. We don't know. I mean, I think my interpretation of the association between amyloid and age is that if you have amyloid and you are asymptomatic at age 80, you are not likely to develop symptoms because, just to put it bluntly, because you're probably going to die before you develop symptoms if you hadn't already. But the argument here that, and just to be the devil's advocate, is did she already develop symptoms? Did she have amyloid for long enough and now she's symptomatic because of it? Is this an atypical presentation of Alzheimer's disease? And her memory performance
It's not too
was,
bad.
she actually recalled all three. Oh, and neuropsych said she did have some memory deficits. So what say you? Am I able to persuade you that removing amyloid may be
Um, no,
a
she's still
desirable
atypical.
outcome?
She's still atypical. I would not, I don't know.
I would
Sorry,
agree with
Dr. Najib.
I would agree with that, but it's for the sake of discussion. Let's say they're really pushing, which they are. Dr. Najib, what would you do? How would you get out of it?
I would refer the patient to you. Wallah, it's difficult.
That's hilarious. That's why you're the master. Um, I mean, I think what we did, she has really two wonderful sons. She had two amazing sons. And that one of them is a social worker and the other is, they're both very intelligent, and they're able to ask you these specific questions about the clinical trials and what it means and so on and so forth. And I think I think right until now, I'm able to tell them that I don't really know, and that if I don't know, we shouldn't really gamble. And then she's a little bit unstable because I think she's close to the debilitated condition, even though she would probably still be, if she had a typical episodic memory pattern, she would be included in clinical trials. No, she wouldn't be debilitated per se, but I think there's just so much going on that I don't feel safe giving it, is what I told them. And I think that was key. And again, a person rushing into this, like I may have rushed into that other case, could end up giving the patient, committing the patient to the course. Walid, what would you do if you're still with us?
Actually, I would be very hesitant, honestly, and I would try my best to persuade them away from the medication, given the what you mentioned, and also the anticoagulation piece. Although trailer
Yeah.
base didn't show the risk, but still, I feel comfortable following the AUC, like appropriate use criteria set forward. Um, I will have that. It would be really hard to argue against it, like in court or something. So I would
Yes.
caution and do my best to persuade them against it.
Great. Excellent. I agree with you. Good. I think, Ru'a, what would you like to do with, should we stop and open it up for additional questions from the audience? We haven't had enough of a discussion with the audience. I do have a couple of other cases, if you'd like, or we can stop here. It's been an hour and a half already. You're the boss.
Um, I've been following the questions. There are no questions so far, other than the CME hours. So let me just some housekeeping. So in the registration link, we've specified the target audience. So those who fulfill the criteria will have the CME hours approved. For those who do not fulfill the criteria, um, will be receiving this certificate of attendance on the email that you provided upon registration. We don't have questions so far, so if you would like to have a couple of more cases, I think we can do that.
Sure. I think let's do this case. It's an interesting case. I may have told you about it, Ru'a,
Yeah.
but I'd love to hear people's thoughts as well. So this is an interesting story. So 75-year-old, again with a behavioral change. Family comes in and says he's not the same person anymore. That's been developing over the course of the past 3 years, or since I saw him, so a few years. He's a retired mechanic who was the life of the family. Um, Sometimes I feel like I'm developing hallucinations myself. So he was the life of the family. Goes to the gym, very active. Health conscious, and became health anxious. He's some history of atrial fibrillation, and he got rhythm converted, and then he had a recurrence. It was 2019. Then he developed COVID in the height of the pandemic and got really sick with it. Lost a lot of weight. And then subsequent to that, he became paranoid. So he was more reserved, not himself, sitting at home, not doing much. And then he was asking about where his stuff is, where the food came from, who poisoned the food. He started throwing away anything that was in the fridge. And even though he was health conscious and used to very regular his appointments, he became afraid of going to the hospitals and thinking that he might not come home, and potentially thinking that there was something being plotted against him by some other healthcare professionals. And again, he was sort of withdrawn, apathic, not really anhedonic, but just sits there. And even in the clinic, he would just sit there and stare at you. You crack a joke, and me being the hilarious physician, less hilarious than Dr. Najib, obviously, but still, I have some hilarity in me, although my wife wouldn't admit it. In any case, so you throw a joke and he laughs. And he was diagnosed with depression because of all of these behavioral changes, put on these meds, didn't really get better. This is the past medical history. He's on Elquis because of the AFib. And he has no history of dementia, family history of dementia. This was his exam when I first saw him, that flat affect, preoccupied with what's going to happen to his health. Not really clear if he had insight. Reduced verbal fluency, a little bit of executive dysfunction there, and reduced verbal fluency. Mixed up the hands of the clock, normal Luria, no frontal release signs, normal neurologic exam without bradykinesia or tone abnormalities or corticospinal tract signs. This is his neuropsych showing executive dysfunction in a pattern of mild stage dementia of frontotemporal localization, not typical of Lewy body or Alzheimer. So really not a diagnostic neuropsych. This is FDG PET. It was called normal. To me, it is really not normal. And this is the kind of scan where this is higher colors, brighter colors are normal metabolism. Darker colors are hypometabolic. So, I mean, if you look at the mesial temporal structures here, and you just compare to the surroundings, you would definitely call hypometabolism there. And even a little bit in parietally, right? So temporoparietal, if you compare parietal with the more posterior and medial surfaces, you would call hypometabolism. You wonder a little bit about asymmetry here, but in any case, not a normal PET scan. So this is not just depression. Depression shouldn't do this. And the pattern is, to me, it looked like it was closest to what you would see in Alzheimer's disease, as opposed to Lewy body dementia, where you'd see occipital hypometabolism or cingulate sparing. And so that's what I canceled the family. And I said this was probably a form of dementia, mild behavioral impairment, as opposed to mild cognitive impairment. Or actually, he would qualify for non-amnestic MCI since there were abnormalities on testing as well. So the potential pathology being atypical behavioral variant AD versus a dorsal behavioral variant FTLD, with potential vascular comorbid pathology, Lewy body being the differential, the usual yada yada. So recommended, since the picture was unclear, and it was at the time before we had direct access to amyloid PET at my center. So we did the LP, and we also we were looking for autoimmune encephalitis as well, so ordered the antibody panel. And on the right here, you have the criteria for mild behavioral impairment, which basically stipulates, for those of us who are not behavioral neurologists, the onset of a behavioral psychiatric syndrome late in life without clear cause and precipitant and without prior history earlier in life of psychiatric presentations. That's MBI, your MCI equivalent, but in terms of behavioral circuitry. So ordered all of that stuff, and he came back to me with worsening depression. I treated his depression differently, a little bit up titrated some of his meds and so on and so forth, and then later came back improved. And he didn't really want to continue workup. I was not sure he was fully trusting of me. And then a few months after that, I get a call that he was admitted, and they were asking me for goals of care. And I was like, what the heck are you talking about? This is a guy who was still quite functional, lost a lot of weight and was somewhat withdrawn, yes, but goals of care makes you think he's dying or something. Turns out he really did take a turn for the worse, with significant weight loss, continued weight loss, not eating basically, an oral thrush, He had a significant GI workup that was negative. Eventually, his workup only showed a bit of a UTI, for which he got an antibiotics course and improved a little bit and got discharged. This was his exam at the time, a MOCA of 22. Let's see where he lost points. So a bit of frontal dysexecutive. The clock was he lost 2 points with the clock. And in the points he would lose are related to the misplacing the hands and the contour of the placing the numbers appropriately. But he would fix himself. Verbal fluency was 0. Memory was shot as well. So not really significantly aided by, and then he couldn't just get to date. He got the month and the day and the rest of it, but the specific date he wouldn't get. And this was a consistent performance across the different visits. This is his FAQ, borderline, needing help with a lot of things that you see. And this is so, now we're at the age where I get tau 217 and my access to tau 217, it's elevated. Send him for CSF, and this is his CSF. What do you think? It shows a little bit of a protein elevation, just a smidgen. You could pass this as something. I'm not sure. His total tau was elevated, and p-tau 181 is elevated, but his amyloid levels are high. And this was read by the lab as not, we don't need to calculate ratios or anything. His amyloid is not reduced, and recommended a repeat at some point in the future, potentially a situation of early neurodegenerative disease. To me, it looked like it was a tauopathy. And he had a negative, we looked for CJD and we looked for autoimmune encephalitides and syphilis, and it was all negative. Any additional reads from this before I show you the rest of the story? I'm interested in your opinions and feelings.
PET scan, myeloid PET.
Yeah, it's coming. So that's what I did. I was like, wait, this is elevated, this is negative, what the heck is going on? This is supposed to be really good. So I reordered his FDG PET, and it showed the same stuff. You can see different scanner, so but you can see the parietal hypometabolism, and it really doesn't look like an FTD, right? This parietal and then temporal. So this is giving credibility to my initial read as well. And then this is his MRI. Pretty good looking MRI. Yeah, I was wondering about, I'm not sure if you guys see it. There's maybe a little bit of volume loss measly and frontally, but it's just not, as soon as you go a little laterally, it's full. So I'm not sure what to make of that. Subtle atrophy, maybe, is that relevant? Not sure. His hippocampus looks it looks fairly healthy. You can see it on this other image as well. And bingo. So that's his amyloid PET. So BAPL3 indicating amyloid burden. So what would you do? Let me see. What do I have next? So I ended up calling this behavioral variant AD. It doesn't really 100% fit the criteria. He has the apathy, inertia, socially inappropriate behaviors, no really perseveration or anything like that. And he sort of fits given the presence of amyloid, you say, okay, this is behavioral variant AD. The other alternatives obviously being Lewy body. We didn't really look for that yet. and just severe psychotic depression, but why would the PET scan be so consistently abnormal? And why would he have tau in his CSF? So I was thinking, well, my initial hunch of mild behavioral impairment now turns to behavioral variant AD. And we were pondering what to do. And then I get a call, the calls I get because of this patient. So I get a call that he stabbed himself. His wife came down to find him in a cinematic scene holding his grandfather's sword, which he used in some previous war, and in the middle of the living room, was starting to stab himself, and she luckily caught him before he completely went through and through. He ended up having a wedge resection of the stomach and so on. And it was some thinking of whether he was catatonic or not. I think it was just basically akinetic mutism that he was developing. He was admitted to psych for a little while, and they started him on lithium and up titrated his bupropion, and they were considering giving him ECT. What would you do other than stabilize and support? So would you offer acetylcholinesterase inhibitors? That's the easy question. And would you offer amyloid targeting therapies? You're going to say that he's atypical, and I agree with you. But in a case like this, given all of the potential, and acknowledging that you're extrapolating, is there something that pushes you to do something about it? I mean, obviously, when you get a call that your patient stabbed themselves while you were academically sitting in the back of your chair, wondering what to do, you might get an impulse to do something. And I want to hear the things from you that that tell me not to do something. Tell me what you think about the story, please, and we can sort of end there. What did you
Don't do
think
it.
when you heard my story?
Don't give him lecanemab.
Okay, I will not. I'm about to see him actually soon, and I think, first of all, he's debilitated. He lost a significant amount of weight, and this would be my only. Dr. Najib, I'm interested in hearing your perspective on this because I don't have cases where I think this is the only case where I'm calling behavioral variant AD. Even though there's a little bit of discrepancy between the CSF and the amyloid. So the CSF doesn't really look like it's Alzheimer, but the CAT scan looks like it is, like there's amyloid.
Yeah,
So
but you do understand PET scan is highly, you have a lot of false positives. Like, I would refrain because the amyloid, the CSF is not really typical where you would jump and you would say, okay, it all fits. I agree, you want to help the patient. I totally agree. Sometimes you feel like I need to do something, but it's a behavioral variant, AD, which is by PET scan. I don't think it's Lewy body. I mean, nothing suggesting Lewy body, but the tau is very high. The amyloid is high. I'm not sure. I would really refrain from giving the patient medication. I would not give him. I feel bad for him. I would give him cholinesterase inhibitor, so I will feel less bad. But I would not give him Leqembi.
I agree. Yes. I mean, the other thing is you would potentially make the situation worse. And that's part of the reason why I'm highlighting these cases. The rest of the people that I have given lecanemab to are just typical situations. But I want to highlight that there are many, many cases that will enter our clinics asking for treatments or in which we will consider the giving treatments because of the presence of these biomarkers. And I think there's a push to ignore your clinical sense in a way. which I'm still fighting. And I think it's one of the main messages that this is still tricky business. Behavior neurology is still complex. It probably became more complex than it used to be, actually. And clinical reasoning remains of paramount importance. Any additional comments are welcome. I think this is where I am at the moment in terms of how I proceed. If when I get a patient who is typical for early AD, I proceed with hardcore biomarkers, so amyloid PET or CSF, and I get neuropsych and ApoE. And if everything falls in place, I proceed to careful counseling. And for those who opt in, who spontaneously opt in, I proceed. And in cases where I don't find amyloid, it triggers an existential crisis where you continue searching, something like what I've demonstrated to you here. In cases where there's AD, it's not a typical presentation of AD, I get plasma 217, and if it's positive, I go back here and try to pin it down as AD or not. And if it's negative, again, you're in uncharted territory trying to answer those existential questions. Any comments on the workflow? Walid, what do you think about the workflow? What's your workflow, Dr. Walid? If you're still there. Dr. Najib, what's your workflow? Dr. Ra'a.
Sorry, I was on a call, but I had a question for you, Sarah. Is your p-tau 17 donated by the monoclonal the antibodies companies?
Are they paying for it? Not
That's
yet, no.
okay. Like,
No, I order them everybody.
Yeah, okay.
I do.
No, I'm just
I
saying
order.
because they're coming back positive on everyone. So I'm just
It comes back.
wondering.
I think it's coming back at 90% positive.
Okay, I think it's the selection of the being in a memory clinic for sure.
It is.
Yeah.
For
So,
sure.
but I actually love the workflow, and I think it's in sync and in line with the best practice or what's being considered the best practice. Whether this can actually become the best practice here in Saudi, we'll have to actually maybe have further discussion on the availability of most of these technologies and basic diagnostic tests. As you know, like most of them are not all available here. So the readiness for us is something that we really have to consider. But overall, I think it's a very practical and workable workflow, very simple to comprehend and follow. So I salute you for preparing it, and I actually took a screenshot of it to adopt some of this steps. Thanks.
Yeah, this is heavily copyrighted, and I charge for all screen. I'm just kidding. No, I think we should all work together to develop A, the resources, B, the a workflow that works for us, just like you said. And I think it's just you find yourself in clinic making these decisions one by one, but then you want to step back and say, well, am I in line with the appropriate use criteria? How should I create an algorithm like this, and so on? And you notice how I have a dotted line here about preclinical AD, just to remind ourselves that people are going to come and talk to us about medications, even when the clinical presentation does not really fit, but the line leads nowhere. So not yet anyways. We'll see in a couple of years, things may change, but I think we need to we need to stick with what we know. for as much as we can, and especially in the presence of conflicts of interests when they're present. So yeah. Any additional comments? I can
I
leave you
actually have a
guys.
question.
Yeah.
So, in the flow chart that you just showed, why don't you do the p-tau 217 for those who are typical for early AD?
Oh, because sometimes you can call it, maybe sometimes if it looks like it's early AD, I'm not ruling in with the tau 217 yet. It's more of a rule out test. Um, so if I'm going to rule in, because I'm going, it's typical AD, and I think the tau 217 will be positive, I just go ahead with the amyloid PET and CSF. I don't know, that's my reasoning of it. Because if it's positive, I would do the amyloid PET and or CSF,
Mm.
usually amyloid PET anyways.
Okay.
I don't know. That's my justification.
Fair enough. Thank you.
I don't know.
Yeah, I think it's just because now so far we don't have a medication yet, so I kind of I do it for everyone. If it's negative,
Yeah.
it's negative. If it's positive, it's positive. And I think this would change when a medication is there because as you nicely mentioned, like it's going to be positive, so why put this tip in the middle? Let's just proceed. But for the time being, because we're not offering medications yet, so
Yeah.
so that's why I'm trying to understand the flow chart because I know things are going to change even in my clinic very soon when we have different options.
Yeah. Yeah. This is very much a work in progress, and I think we need to I certainly want to learn about your experiences and modify what I do. And again, it's our responsibility. Knowing our limits is one of our main one of the most important competencies that we need to uphold ourselves to. I think in situations like we're all learning, as my mentor told me when I was sharing some of these struggles with learning how to adapt to this paradigm shift. And I think knowing our limits and being humble, medicine is humbling. So I think we need to know our limits and learn from each other, and for the sake of our patients and families. Cool. So these are some of the final some points. Accurate diagnosis is key. We need to do biomarkers, but not depart completely from brain behavior correlation. Staging is important, and counseling is just key. And we must seek each other's help in order to help our patients. And I think we can leave it at that.
Thank you. يعطيك ألف عافية.
يعطيك يا رب.
Thank you everyone for being here. I don't see questions. So again, just some housekeeping if you allow me. So everyone who registered through using their email are going to be receiving their certificates to their email. Anyone who's eligible for the CME hours are going to receive their CME hours. Just allow us some time, please. This may take a couple of weeks. Thank you all for your patience in me answering these questions, and thank you for being here. Thank you, Dr. Haytham, Dr. Walid, Dr. Najib. Thank you for this enriching and insightful discussion. I'm not sure if anyone would like to add anything. Dr. Najib, Dr. Walid, Dr. Haytham, if you have any last words. before we
والله
conclude?
There may be a
I'm
couple of questions. I'm
إذا
sorry, go ahead.
إذا بس تسمح لي الله يحفظك I'm really honored
تفضل.
to be here and learn from you all. But this was Dr. Haytham, this was phenomenal. Really, I got to learn a lot of different things, how things really in the clinic, clinical sense are difficult, and it's really would be wonderful to exchange more of these cases. I couldn't have been happier, and it's really an honor to learn from all of you. Thank you very much.
Allah يعطيك.
Thank you.
You're our teacher. Allah يعطيك العافية. You're our inspirer. You're the godfather, as I always say. I think there may be a few questions, Doctor,
I agree.
in the
طيب,
middle there.
Okay, so
I'm not
someone is
sure.
asking, I asked about the most common type of amyloid with Alzheimer's.
I'm not sure I understand the question. The most common type of amyloid?
Yeah, with Alzheimer's.
I'm not sure which different types we're talking about. There's 4 repeat tau and 6 repeat tau. Are we talking about, for example, A beta 42 and A beta 40 and so on? So we can go back to the biomarker.
Dr. Ali, can you elaborate more on your question? If you can elaborate. So what do you mean about amyloid and Alzheimer's? I'm not sure, Dr. Haytham, if you've seen any other question, because
there may be someone asking about a case. ما هو سبب ظهور الخرف بعمر مبكر قبل 70 سنة؟ هل هو وراثي؟ هل الصدمات النفسية الشديدة لها علاقة بالإصابة بالألزهايمر؟ Do you want to take that, Dr. Roa?
Are these questions أنا مو شايفاهم. Are they directed to you?
It's in the comments. It's in the comments. I mean, it's where the panel, so it's directed to everybody. So, man, anything after 60 is fair game for Alzheimer.
Okay, so yeah, سبب ظهور الخرف بعمر أقل من 70 سنة. Okay, yeah, go ahead. Would you like to answer that?
I was just quickly going to say, because of time also, anything after 60 is fair game. There are ما أعرف إذا كان المفروض أجاوب بالعربي برضو. هناك أنواع وراثية للمرض، ولكن الأنواع الوراثية اللي هي الأوتوسومال دوميننت، الوراثية القسرية، تحدث عادة في أعمار أقل من كده، في الأربعينات والخمسينات. بس في زي ال ApoE، احنا we talked about ApoE, it's one of the risk factors. بس في risk factors كثيرة اللي past 60 for Alzheimer. هل الصدمات النفسية شديدة علاقة بسبب Alzheimer؟ If we're talking about trauma early in life, as far as I understand, there's no direct evidence that there's a relationship. ولا أنا غلطان؟ Trauma early in life, الصدمات النفسية الشديدة, there's no direct relationship. Psychiatric symptoms can be an early manifestation of dementia. And people who have psychiatric syndromes are at a higher risk of developing dementia later on. Meaning, if you have depression late in life, you're at a higher risk than if you didn't develop dementia. بس لكن التعرض لصدمة نفسية واحدة أو حدث شديد ما يسبب Alzheimer, if that's the question.
Okay. So the types of amyloid. So the amyloid, the ATTR, the amyloid AA that are known to cause the systemic amyloidosis are not the type of amyloid that we're talking about here. So we're talking about amyloid beta, 42 and 40. These are the normal amyloid that's present in the brain, but then somehow, for some reason, alteration in the structure of this amyloid results in it becoming sticky and precipitating in the brain. So it's a different type of amyloid. The other question was, what should be the first investigation of choice when you're suspecting Alzheimer's disease?
Yeah, I think that takes us back to the flow chart.
Yeah.
So I think first of all, you rule out mimics, masqueraders. So you want to get brain imaging, thyroid, B12, sleep study, etc. And then if you can get p-tau 217 if you are comfortable interpreting it. But what I really, if you're not a behavioral neurologist or dementia trained physician, what you can do is do your neurological examination, general examination, cognitive screening with whatever tool you're comfortable with, and then just refer the patient to somebody with experience in this. And then in the behavioral neurology clinic, people typically decide whether to go with plasma, and this will probably change in the next few months, depending on what more data, but people will decide whether to do plasma or CSF or amyloid PET or FDG PET. And these are complex decisions, just like some of the cases highlighted and like the algorithm highlighted. That would be
Amazing. Thank you.
my answer. Yeah.
Okay. I guess that was the last question we had in the Q&A. Okay.
ممتاز. الله يعطيكم العافية.
So much. Let's have more of these.
Absolutely. This was good. Let's have more of them for sure.
Sure. Thank you. يعطيكم العافية. Good night, everyone. See you next month,
سهلا
inshallah.
جميعا.